Hello everyone, myself Dr. Akshat Jain, and today we'll be seeing this video which is based on managing a complication that is stent dislodgement. So from mishap to mastery, the art of retrieving dislodged stents. So this was the case summary. This was a 48-year-old female who was admitted in midnight with chest pain. ECG showed STEMI anterior wall MI. Patient was loaded in a standard manner. Echo showed LAD territory hypokinetic, and angiography was pretty much looking as a single vessel disease and a thrombotic lesion. So I planned to go ahead with a direct stenting. I took the first stent, it was slightly small in length, so decided to exchange for a longer stent, pulled out, but shocked to see that only balloon came out. The stent was left in left vein. So now what to do next? So complications can happen to anyone at any time. So what is important that you must know how to manage it and what are different ways to manage it. So first I took a small balloon 1.5 into 10 balloon inflated at a nominal pressure at the center of the stent. However, balloon slipped inside the guiding. I could not retrieve the stent. Then I decided to take a larger balloon, put it at the distal end of the stent, inflated it above the nominal pressure, and while pulling the proximal part of the stent got crimped, so it crimped against the guide, likely due to non-coaxiality. So I decided to pull the whole system out, but the balloon slipped into the guiding again, leaving the crimped stent in the aorta. So now the thing is that while attempting anything as of now, I could lose the stent which could embolize to the cerebral circulation. So to avoid it, I used the natural flow of the aorta, pulled the system slowly into the descending aorta, and then I tried crossing another new balloon. However, it could not cross through the crimped stent. So what did is I took two another wires and passed them beyond the stent. I inserted all the three wires, the proximal end of those, in a single torque, rotated torque multiple times such that the distal portion of the wires got intertwined or looped, and then I pulled the stent with support of distal wire loops that avoided the distal migration. So finally I could retrieve the stent, and then this was the final angioplasty. I took the same guiding, same wire, a longer stent, did direct stenting, dilated with NC balloon, and then the post dilatation slow flow was managed with intracoronary adenosine and adrenaline, and it was a good result. So stent dislodgement could be due to many reasons. It could be lesion related due to tortuosity, calcium, severe fibrosis, underprepared lesion. It could be operator related, that is forceful pulling or pushing, not maintaining coaxiality of the guide while pulling, and inadequate stent expansion. And sometimes it could be stent related itself, that is there are some brands and manufacturing issues with some brands. I would not like to name them, but all cardiologists, interventional cardiologists know it. And also the large cell design sometimes comes of at the risk against the cost of flexibility. So the art of retrieving the dislodged stent. So we could have three kind of situation. One is wire is across the stent and the stent is across the lesion. In that case, we can dilate the stent serially with a small to large sized balloon and deploy the stent in the vessel. Another scenario is wire is across the stent, but the stent is not at the lesion. So in these cases, we can dilate a small balloon in proximal part of the stent at suboptimal pressure and pull it inside the guide while maintaining the coaxiality. Or we can go to distal to the stent and then take 2 to 2.5 balloon and dilate and pull the whole system out. Another method is cross two or more wire distal to the stent, put the proximal part of these wires in a single torque and then rotate them rapidly in the same direction such that a stent gets strapped with distal wire loops and then pull the system out. If all these methods fail, then again you can go to the options available in the first or third column. So another scenario could be that the wire is not across the stent. So one thing is that we can try crossing wire through the stents and try the steps as mentioned in the first and second column. Second thing that we can try to snare and pull the stent. And third is we can cross the wire beyond the dislodged stent, crush it to the vessel wall, followed by deploying another stent across the crushed stent. But I would always advise and prefer to remove the stent and not crush it. The reason being, a crushed stent leads to multiple layers of stent. The long-term risk of restenosis and the short-term risk of stent thrombosis is high in such cases, which can hamper the patient's safety. So we should avoid this and use it as a last resort. So the take-home message is complication can happen to anyone at any hour. Be ready, be prepared. Patience is the most important attribute while dealing with complications. There is always another method when the first fails. Avoid direct stenting whenever possible. Avoid pulling and pushing the stent without fluoro when inside coronary. Try to maintain coaxiality of guide catheter at all costs. Thank you.